Okay, so if you look at this is the eye trace, you have seen it before. So what makes it so special basically? So what happens is that in the eye trace, we have a series of infrared laser points which are fired into the eye, and these are individually then analyzed. So that is where the eye trace differs. It's an auto refractor, it has a topography, it has a ray tracing aberrometry, it has a pupillometry, it is an auto refractor keratometer, right? And so look at this beam, so and see where it is falling on the retina. So each beam is falling separately and is being analyzed separately. So a set of 64 spots is fired 4 times to generate what is known as the point spread function and the retinal spot diagram. And this is what it contains: all the information about the refraction of the eye, the aberrations of the eye, and the optical and visual function of the eye, both qualitatively and quantitatively. So the sphere and cylinder are obtained through calculations which are based on the Zenik's coefficients. It has a very, very efficient optometer, which is known as the Badal optometer, which is used to generate accurate data. So if we look at the range of the autoref, it is plus minus 15 diopter sphere, plus minus 10 diopters of cylinder, and it can measure through a wide variety of pupillary sizes accurately, both 2.5 to 8 millimeters, and it has an excellent accuracy and reproducibility. So what makes the autoref special in this case? Again, we want the autoref readings to be as physiological as possible. So what it does is that it gives the patient a highly blurred target, a plus 7 diopter blurring for emetropic eyes. So this is a featureless target, and 20 examination laser spots are then fired to acquire the data to calculate the patient's spherical equivalent. Then what happens is the target is then moved from the far point to the patient's to a near point plus 1 diopters. So so what the patient classically sees, if you sit on the eye trace, I'm sure it will be there in the exhibition. So you'll see a small, relatively featureless but defocused on the side of plus focus. So this actually gives a very, very accurate reading. There are several studies which have been carried out, and I did my own autoref reading. It is very, very accurate compared to the manifest refraction, so to the tune of less than 0.12 diopters. The condition is that the accommodation, we know, has to be relaxed, and this is where it scores over other autoref instruments. So when we talk about multi-zone refraction analysis, what happens is it gives us different zones at which we can then see the refraction. For example, if the patient comes and says that I have problems with my night vision, especially after refractive or cataract surgery, and it leads to a post-operative dissatisfaction in the patient. So what we can do is we can track these changes. What happens during the daytime? What happens in the evening? So if we take a close look at the refraction of the patient now, as Professor Tityal was saying, any tracy refraction, it is color coded. If it comes in red, it means your red flags should be up, and usually it is something which might require a surgical intervention. It's not going to be corrected just like that. But if you see, as compared with the size of the pupil, you'll see as the pupillary size is increasing, the refractive error is, of course, the main culprit here is the increased spherical aberration in this patient, but the complaint is that of night myopia, and this explains it, and it's very good tool to explain to the patient also, you know. And of course we also know that the larger the pupil, this has a visual simulator. So this has an e which is displayed, but you can talk to the patient, you can show them what is the problem and how we are going to correct that. So in a smaller size pupil, of course, the e will become clearer. So we know that there are different types of 20/20. We want our patients to have the best quality of vision which is possible. Now if we look at the point spread function, what is point spread function? So it is basically what a point source of light looks to the patient, how it looks. So if it is a very aberrated wavefront, it will be an aberrated point spread function instead of being a very compact kind of a source of light. It is also displayed in a 3D mode. So you want to see something like an Empire State Building. You don't want to see something like the Himalayas spread all over. So there is a very quantitative way that we can express it, because when we quantify things, makes it so much easier for us to analyze it. We may not understand how that quantification is arrived at, but strahl ratio is the ratio of the peak focal intensities between the aberrated and ideal point spread function. So ideally it should be 1, and the lower the reading it is, we know the worse is the style ratio of the patient, worse is the visual quality of the patient. You just take a look at the style ratio and you know that something is very wrong with the patient. Now the point spread function is of two types. One is the total point spread function and the higher order point spread function. Like the higher order aberrations, higher order point spread function cannot generally be corrected by conventional means in this patient. So it can be used along with the vision simulator chart to understand and explain the patient symptoms when we are working up a patient. For example, simple thing, is the patient going to benefit from glasses, spectacles or not? Sometimes it's a very small question, but we are in a fix. So it shows you without spectacles and with spectacles, the kind of point spread function, and it makes us more confident in prescribing just a simple spectacle correction. For example, also in cataract surgery, how the patient's eye is behaving post cataract surgery. Now, another very poorly understood function is a modulation transfer function. Now, we know that we are calculating a contrast of the patient, such a tedious job for us to do. It's we have to spend time explaining to the patient. Here, a 2-second reading gives us a very good idea of what the patient's contrast might be, and that is expressed by the modulation transfer function. So this is derived from the point spread function. It's the eye's ability to transfer the contrast from the image to the retinal plane. So this is basically, this is the contrast sensitivity of the lens system. And this is again one of the units of the visual performance. So modulation ratio is the ratio of the image contrast to the object contrast. So the actual contrast of the object and the image contrast, right? So it comes in this graph, and the contrast is represented by the y-axis, and the spatial frequency is by the x-axis. Now, what do we mean by these terms? The contrast and the spatial frequency. Basically, if you see a grating, you will see that as the spatial frequency goes up, the grating becomes finer, closer and closer, till it becomes a blur to the patient. So an eye with a high mtf will be able to see things better, smaller labels better than an eye with a poor mtf. So if we are talking about some area here, it would probably mean you're reading a billboard, and a normal writing would be somewhere in this area, and a smaller label way down in the spatial frequency. Now this ITIS gives us a red box, and this red box is 40% contrast and 10% spatial frequency. Anything which is above that is considered that the patient's vision is going to be satisfactory. Is my timer? This timer is not on.
Yeah.
What? Can I go? Yes.
Can you wind up because we are going to?
Okay.
Yeah.
Right. So essentially, so this helps us in making in decision making also in the refractive surgery in these patients. So this is all about, I think so many other aspects of the eye test are being discussed. This is what I want to talk about. Thank you very much.